The following is brought to you by VerticalVet. Rethink your GPO.
Hello, VerticalVet family. I am Dr. Ernie Ward, Chief Veterinary Officer for VerticalVet, and today is one of those days I just live for. We are going to be talking to a cardiologist about one of my favorite conditions. That's mitral valve disease. And not that it's my favorite condition, but it's one of those conditions that we see in small animal practice that we can do so much about. And I think sometimes we overlook, forget, just get too busy, and we don't always optimize what we can actually do. So I just cannot wait to get started with this discussion today. Today's discussion is brought to us by our friends and partners over at Boehringer Ingelheim. BI brings us an entire palette of drugs and treatments that we can use, and we're going to be talking about some of those today. But let's get right to our guest today. We've got Dr. Lance Visser all the way from Colorado State University. He's going to be talking to us about the latest advancements and what you need to know about mitral valve disease. But a little bit about Lance in case you're not familiar. He is all the way from Grand Rapids, Michigan. He obtained his BS and combined DVM MS in 2010 from the Michigan State University. He then went to do his internship at North Carolina State University and finished that up in 2011, then goes on to do his residency and MS program in cardiology at The Ohio State University, finishing up in 2014. He recently joined Colorado State University, where he is an associate professor of cardiology. Prior to this, he was at Cal Davis, great school also, and his primary interest is in researching and improving non-invasive assessment of cardiac structures and function in animals with cardiovascular disease. Lance, I am thrilled to have you today as a guest.
Dr. Ward, it's a pleasure to be here. I'm really excited. I really like what you guys are doing, love the format, and I'm just happy to be a part of it.
Well, we look at VerticalVet. We are here to try to help our members, thrive and grow. And look, and this is an area where, companies like Boehringer have really changed the game, in my opinion. But today, before we get started, because we're going to talk about all the kind of what you should be doing as far as assessing and treating and the prognosis and diagnosis, all this kind of stuff with mitral valve disease. For those maybe newer, younger vets, let's just do a quick refresher. When we talk about mitral valve disease, what does that mean to you, and what do you hope to share with us today?
Yeah, absolutely. It never hurts to kind of go back to just a brief reminder of making sure we're on the same page with what this disease is. So first and foremost, it's by far the most common type of cardiovascular disease that we see as cardiologists, but also seen out there in general and urgent care practice. So, largely what we mean when we say myxomatous mitral valve disease, and by the way, that's the same thing in my view as degenerative mitral valve disease, as chronic mitral valve disease, as mitral valve endocardiosis. We can hopefully just ultimately decide on what to call it and stay consistent, but you'll hear a variety of terms. So what that is, or what that means, is it's an acquired disease, and most dogs are going to get this abnormality of their mitral valve, right? The mitral valve is intended to prevent backflow of blood from the left ventricle to the left atrium. But in a lot of dogs, especially as they age, as they get into that latter 1/3 of their life, they, for unknown reasons, develop these degenerative changes to their mitral valve, where not only the valve, but the chordae tendineae holding the valve to the ventricle itself, or the papillary muscles, can degenerate and become, function improperly. The valve thickens, becomes kind of bumpy and irregular. And to make a long story short, that will ultimately end up in mitral valve regurgitation. So every time the left ventricle pumps, you're going to get a certain amount of blood leaking backwards into the left atrium, as opposed to heading out to the body through the aorta. Fortunately, most dogs, especially small breed dogs, are going to get this when they're quite a bit older or well into their lifespan, 10, 11, 12 years of age, for example. And because it's a very slowly progressive disease, in most of these dogs, nothing bad happens. But clearly, in a large number of dogs, we can begin to see clinical signs, or so-called symptoms, or even this can progress to congestive heart failure, difficulty breathing, fluid retention, and even end organ damage, kidney damage. Because if our heart's not working or pumping blood to the body, we can start to see several other organs suffer. So yeah, this is a disease that clinically manifests as mitral regurgitation, and most of us are going to experience that as an incidental heart murmur. So that dog might present for another reason, a wellness visit, something like that, and you're going to be first exposed to this by a cardiac murmur. So that's how I would summarize it or kick things off in a nutshell, and I'm sure we'll delve into different aspects.
Yeah, and I love that. A couple of quick things, too, it just as a practitioner for over 30 years, this is one of those surprise diagnoses, in my opinion. Oftentimes, you've got this little small breed dog in front of you, everything's just fine, and suddenly you put that stethoscope on and you're like, whoa, there's a washing machine in there. How'd that happen? And often they are asymptomatic. It seems to be quite later in the disease course when they become fulminant. And of course, if the dog comes in coughing with all kind of other clinical signs, it's way too late. But I love the fact that this is one of those diseases you've got to be attentive for, because if you can catch it before those symptoms develop, you may save a lot of trouble. The other thing too, I like that you mentioned, Dr. Visser, was the fact that this is the most common form of cardiac disease that we see. And last few years, the limelight, the spotlight has been stolen by that other thing called DCM, and I think a lot of vets maybe forgot to look for mitral valve disease. And so I want to kind of kick off today's discussion with, how do we diagnose it? What are some of those clinical signs? I mentioned it's a surprise to many of us. So how do we go about diagnosing and evaluating a dog that might have a murmur, and how do we even determine if it is a mitral valve versus some of the other valves in the heart?
Yeah, absolutely. And just to build off what you said, I think our first hint of this disease is based on using our stethoscopes and just looking at the patient based on signalment. So this disease will affect, typically an older small breed dog, but keep in mind, large breed dogs can be affected by myxomatous mitral valve too. We certainly start to think a little bit more toward dilated cardiomyopathy in our large breed dogs, but I would argue myxomatous mitral valve disease is just as common as dilated cardiomyopathy in large breed dogs. Fortunately, they tend to behave pretty similarly, so there's not huge differences in the approach to DCM versus mitral valve in large breed dogs. But our first exposure to this disease, like I said, is usually, or as you mentioned as well, an incidental heart murmur. And that in some breeds we know can manifest at an earlier age. The Cavalier King Charles Spaniel is certainly the poster child, but also Whippets, Poodles, Dachshunds. They might get the disease at a relatively younger age. So 5, 6, 7 years of age, whereas most dogs, we don't hear a murmur till they're in that latter 1/3 of their life. So the murmur is typically a left apical or left-sided systolic murmur. Now, one thing that can be challenging, the smaller the dog, the harder it is to localize the murmur. So we try to differentiate murmurs in two main areas on the left side of the thorax. So either the left base, so that's more in the armpit region, the axillary region, the base being somewhat of a misnomer, being the top portion of the heart, versus the apex. And I will admit, it's sometimes hard to differentiate. But again, your biggest tip, or at least hint of this disease, is a left apical systolic murmur. So from there, I think once you hear that murmur, and you're dealing with an older small breed dog, for example, already, if we just run down the list of other possible causes of that murmur, the other possible causes you quickly realize are pretty uncommon. So we're almost starting with a presumptive diagnosis of myxomatous or degenerative mitral valve disease in these patients. Because what are other things that can cause mitral valve regurgitation? As you mentioned, dilated cardiomyopathy. Despite this scare with some of these non-traditional diets being linked with DCM, that's a rabbit hole for another conversation potentially. It's still not all that common, fortunately, particularly in the smaller breed dogs, but it is a differential. Mitral valve endocarditis. These are usually very, very sick dogs that have septicemia or bacteremia with an infection that's set up on their valve. Fortunately, that's really rare and not common, and very, very unlikely in an otherwise healthy dog or a dog that's only coughing, for example. And then we have some congenital diseases that might also cause that murmur, but that's going to be in a relatively young dog. So that's why you can quickly see the other potential causes of these left-sided systolic murmurs. Really, you're only left with a pretty high likelihood that we can make a presumptive diagnosis of myxomatous mitral valve disease.
Yeah, and I'm really glad you said that because, we always try to teach our young vets that first and foremost, if it's a small breed dog with any murmur, we presume that it's a mitral valve till proven otherwise, right? So that's like a good starting point. But the other thing too is if you're a new young veterinarian and you feel unsure about I don't know if it's at the base or the apex, I'm having a hard time. Look, I'll tell you, first just get it down sides. And it is so much easier, I think, Lance, than people realize to actually differentiate a left-sided murmur versus a right-sided murmur. You can really clearly distinguish the differences, right? Any other little tips with the stethoscope? Because I have found that for me, the stethoscope is one of the most important tools in my daily armamentarium for diagnosing disease. But I think many people are still intimidated by it. Any bits of advice or tips that you might have for that young vet who's going, look, I don't know what I'm hearing in there anyway. Sometimes it's a whoosh, sometimes it's a swoosh. I don't know the difference. What should I do?
Yeah, absolutely. I think it's a little bit hard without hands-on, but I still think, murmur yes or no is kind of the first question. So that's a start. But trying to localize it even to one side of the chest versus the other, and just where the point of maximal intensity is. And then the finer tune localizing, like I said, even sometimes we struggle with that. But a good quality stethoscope, using a more pediatric stethoscope diaphragm can help. And a lot of times it's just experience in knowing what to look for. So practice, and maybe relying on more experienced practitioners to kind of just confirm your findings. I think that can also be an invaluable resource. You bet.
And one thing too, I'm sure it's way out of date, but back when I was a young vet, and look, I started my practice 14 months after graduation, so I was all on my own. But I bought a series of, believe it or not, cassette tapes that had a bunch of human heart murmurs. And we didn't have them for vets back in the day, but does anything like that exist? Because I would listen to these things over and over, and really, I think it tuned me in, no pun intended, to what to listen for.
Yeah, absolutely. The one that comes to mind, I think there are still books out there that might have recording, but on VIN, you can find the Veterinary Information Network, a library of heart sounds. Because like you said, I think sometimes half the battle is knowing what to listen for. That's at least a place to start. And then, I always tell students, as nerdy as it is, or people that want to improve auscultation, listening to the heart sounds with your own stethoscope, even putting up to the speaker, can help, because that's going to help mimic real life as much as possible in that scenario, so to speak. And then again, finding an experienced colleague that can confirm your findings, just getting it with your stethoscope, with your ears, with your brain, etc. Just knowing what to listen for. Hey, that is a continuous heart murmur, or that's a systolic murmur, or that's a gallop sound, or that's a click, etc.
Yeah, I love it. And it's not that hard. You guys can do it. If I can do it, you guys can do it. Okay, so now let's say we're in that exam room. We've got this small breed dog. It's a 13-year-old, asymptomatic, but suddenly we're hearing a left apical murmur. What's the next step that we should do? Because, again, I think there are a lot of people that just say, oops, referral to a cardiologist like you, Dr. Visser, but I think there are probably some other things that you should be doing more immediately.
Yeah, absolutely. If we're going by the book, which is probably the best place to go, we kind of already alluded to that, coming up with differential diagnoses for that left-sided systolic murmur. But at the end of the day, if it's this 13-year-old dog we're talking about, you can be 99% sure it's myxomatous mitral valve disease in an asymptomatic dog. So what can you do from a non-specialty practice standpoint? Well, absolutely many, many things. I guess to kind of best case scenario, though, I do think it's important to talk to the owner, talk to them about the high likelihood we already know what we're dealing with. However, to confirm that, and I would argue get some more accurate or precise ways of determining heart size, heart function, ruling out other comorbidities or other complications of this disease, complicating factors, so to speak. That's where an echo cardiac ultrasound is going to be invaluable. I certainly understand that that's not possible, probably in the majority of cases, the majority of the time. But I still think it's worth educating the owner and offering it to them. I'm also, as a cardiologist, not going to stand here on my high horse, so to speak, and say that has to be done by a cardiologist. Is that best practice? Yes, it probably is. However, with some practice, with some CE, I'm a big believer in that being a powerful tool in your practice, with as long as you go about it, in an organized learning fashion. I think ultrasound is becoming, and already is, and is becoming more and more of a powerful tool for general or urgent care practitioners. So offering the cardiac ultrasound, if the owner declines it, like you alluded to, I still think we can have a lot of success managing this disease from a general or non-cardiology practice standpoint. So let's assume we can't do an echocardiogram today, or maybe you got it scheduled. What can we do at this visit? Well, probably the most powerful tool in this scenario is thoracic radiographs. For numerous reasons, it's going to help us establish a baseline for that patient. We know this is a progressive disease, so it's only likely going to get worse. So we can get a baseline largely of heart size, but also of what the lungs look like when this patient is asymptomatic. So in a sense, it's unlikely that an asymptomatic patient is in heart failure, but it's possible, particularly if the owner is busy working or isn't monitoring their dog that closely. So sometimes we can catch congestive heart failure early, and thoracic radiographs are going to be at least the imaging gold standard way, in my view, to determine that. Another value, a huge value, particularly in an asymptomatic patient of thoracic radiographs, is if we can't do ultrasound to look at heart size, chest x-rays are going to be the next best thing. And so the slide that's brought up is showing some more quantitative or objective ways of looking at heart size. So there's just two examples here. On the left, we have vertebral heart score, or VHS. And then on the right, we have another relatively newer way to quantitate heart size. And it is more specific to the left atrium. So that's called vertebral left atrial size. And we may go into more detail on these, but these can be immensely valuable to kind of serve as surrogates for the echo. And there's been studies that have been looked at that to help us guide how we stage this disease, and most importantly, how we treat it. So thoracic radiographs, even in an asymptomatic patient, are immensely valuable. Again, to serve as a baseline in that patient, to rule out left-sided congestive heart failure, and to look at heart size. Because a theme of myxomatous mitral valve disease, if you will, is size matters. So the bigger the heart, the higher the risk for heart failure in that patient. The bigger the heart, the worse the prognosis overall for that patient. The bigger the heart, and we may get to this later, the higher the anesthetic risk. So in addition to thoracic radiographs, you can certainly do other diagnostics. At least establishing a baseline systemic arterial blood pressure is going to be helpful information, and that's potentially something to monitor, biannually or yearly at least, because we know that systemic hypertension, although cardiovascular disease like myxomatous mitral valve isn't going to cause systemic hypertension. Systemic hypertension is relatively common in older small breed dogs, and it can worsen their valve disease. So we want to know about that. Now, it's sometimes an art of acquiring an accurate blood pressure reading, and maybe that's another talk or conversation in and of itself. But we're really ruling out big trends. Is this patient overtly hypertensive? So we want to know about that. And then in addition to that, it does depend on a case-by-case scenario. So if you're planning to do general anesthesia in that patient, certainly baseline blood work can be beneficial. Depending on which medications you may or may not need to start, baseline blood work, particularly focusing on renal function, might also be a good idea. So I would say those are the big keys. Offering the echo, and it's okay if the owner decides not to go see a cardiologist. You can do the next best thing and evaluate thoracic radiographs, assessing heart size. And then at least obtaining that baseline blood pressure is going to be those are going to be great places to start for patients like this.
Yeah, and and Lance, I'm also really appreciate you mentioning blood pressure and also vertebral heart score and VLAS, because I think that those are, I found them to be highly effective. I mean, it gives me a baseline, it gives me something a little more, objective than just looks like a big heart to me, which you can patently see. But, I do think it's nice also to track progression. And I've seen many patients, sort of start to come down on the vertebral heart score over time, especially with certain treatments and so forth. So I really appreciate you mentioning that for sure. And I like what you said too. Start off by having this conversation with the client, because, just inform them, and, you never know. They may say, great, let's go to the nearest university and have a cardiologist. Or they may say, what can you do today, doctor, that's less expensive or that we can handle without a big amount of travel? Okay, so let's say now we've got this diagnosis, presumptive mitral valve disease. What are we going to do as far as treatment? Because there's a lot of really advances in my 30 years. I mean, it's changed a lot. And so maybe bring us up to speed on what the current standards of treatment are.
Yeah, absolutely. And I think a good place to start is kind of what you alluded to with the classic, or probably the most common clinical scenario in general practice. And that's a dog that needs a dental, for example, or is presenting to you for an unrelated reason. Maybe it's lame, knee pain, etc. But now you do your physical exam, and incidentally, there's this left-sided or left apical systolic murmur. So we've already talked about it, making a presumptive diagnosis and at least recommending the echo. But next best thing, if the owner declines or it can't be done, is, I would say, using heart size and ruling out congestive heart failure with thoracic radiograph. So for me, step one, determining if that patient is in congestive heart failure is most important. Now, again, it's going to be very, very, very unlikely in an asymptomatic patient. Usually they have pretty obvious clinical signs of breathing difficulty, plus or minus cough, maybe syncope or collapse if they're in congestive heart failure. So I think it's a fairly safe assumption, but worth evaluating the lungs on the thoracic radiographs to make sure there isn't pulmonary edema. And that in and of itself is a little bit easier said than done. But assuming we're confident that patient does not have pulmonary edema and is asymptomatic, here we're kind of talking about subclinical or preclinical myxomatous mitral valve disease. And this is a very diverse range of patients. So they can have mild to severe disease, or at least mild to severe mitral valve regurgitation, and not show clinical signs. So the question, probably the million-dollar question is, okay, if I don't have an echo to help me decide when to start treatment, what can I do in that scenario? Because what we know from a now famous clinical trial, somewhat affectionately termed the EPIC study, is that dogs that are subclinical, not showing any clinical signs for their myxomatous mitral valve disease, provided they have a certain degree of heart enlargement, we know they'll benefit from pimobendan therapy to prolong the onset of congestive heart failure, as well as prolong overall survival. And so this clinical trial, the EPIC study, the way it enrolled patients or determined they had clinically significant cardiomegaly was largely with an echo, or at least, in my opinion, those are the most important measurements. So fortunately, all that to say, we now have several studies that have used these objective measurements of heart size to help serve as reliable surrogates to say, yes, their heart is big enough to where they will benefit from getting started on a drug like pimobendan, even though they're asymptomatic. So maybe we could just bring up that slide again. And so again, these are measurements. The vertebral heart score has been around a long time, so a lot of us have familiarity with it. And it's in this disease and in this context, again, it's a very reliable way to determine if a patient with presumed myxomatous mitral valve disease has clinically significant cardiomegaly. So the example I have on the slide there is 13.2 vertebral bodies. So a good cutoff that is now on the new Vetmedin CA1 label, provided you don't have an echo or that's declined, a good cutoff to remember that designates or is very likely to be significant cardiomegaly and should prompt starting Vetmedin is 11.5 vertebral bodies. So the patient in this example has quite a big heart, so it's well above 11.5. So if you did this measurement in an asymptomatic patient, I think you should feel very confident about starting a Vetmedin in that patient. Same with vertebral left atrial size, or what's called VLAS. If their VLAS value is above 3 vertebral bodies, also I think you can be really confident about starting that patient on Vetmedin. Now, VLAS is a little bit different from vertebral heart score, and I will admit my bias. I was a part of the team that came up with this score. We adapted it because it's more specific to the left heart. It's kind of directly measuring the width of the left atrium, whereas vertebral heart score is measuring more the overall cardiac silhouette. However, I'm not going to say VLAS is better than vertebral heart score within this context. You don't have to necessarily do both of them. I would just pick at least one. And as you alluded to earlier, Dr. Ward, I think it definitely should be used in concert with our subjective impression of cardiomegaly. And it's, I think, particularly well suited for those practitioners that don't look at thoracic radiographs, that aren't radiologists, or the more novice veterinarian. So it brings some objectivity into when to start. And the reason to be objective or to use these quantitative measurements is important in that we don't, at least in my humble opinion, don't just want to start every dog out there with a left apical systolic murmur or a left-sided systolic murmur that's asymptomatic on Vetmedin. And that's not because Vetmedin has a lot of side effects. It's a very, very safe drug. It's because if you understand the natural history of this disease, kind of what we alluded to earlier when we started this conversation, that this disease is quite slowly progressive in the vast majority of dogs. So a lot of dogs out there with these murmurs, with presumed myxomatous mitral valve disease, they're years away from developing clinically significant cardiomegaly. And someone's got to pay for the drug. So I would rather start that medication where we have good quality guidelines by the ACVIM. And now several studies evaluating these radiographic measurements that largely agree, which how often does that happen, in describing to us when we should start this medication with a high degree of confidence, particularly erring on the side of specificity. So just another quick example of these clinical trials in the EPIC study, where half of the dog were randomized to pimobendan, over 300 dogs, so a huge study, and half of them got placebo. All of these dogs were judged to be at significant risk of congestive heart failure. But even the dogs that went on placebo, so they got no treatment, on average, they took 2 to 3 years before they developed congestive heart failure. Now, of course, that's an average, so some dogs were longer and some dogs were shorter. But again, in my opinion, you want to be hitting these objective measurements or cutoffs before committing that dog to lifelong treatment with Vetmedin. Not because it's an unsafe drug, but because they might not need it for several years. So we want to use evidence-based medicine, in my opinion, to help guide us when to start that medication. So as far as starting other medications in this so-called stage B, which is just another way of saying the dog has myxomatous mitral valve disease or is presumed to have it, but they are not yet showing clinical sign, that is a little bit more contentious or debated. But I think the evidence is strongly in favor of starting pimobendan, provided they have clinically significant cardiomegaly, which again is ideally determined by an echo. But if we don't have an echo, we have good surrogates using these measurements that you had up on the screen.
Yeah, and again, differentiating it's really important, the B1 versus B2, and that old cutoff of 11.5, for the vertebral heart, it's holds, it's still relevant today, and so I like that. I'll also say, in addition to pharmacology, there are a lot of other steps that we should be taking. So again, we're back to that 13-year-old in the exam room, everything's okay, but I think there, for me, there's going to be several other things I might that just include lifestyle interventions. For example, if they need to lose a little extra weight, no surprise coming from me. I'm going to talk about weight management and weight loss in particular. But what about other things like perhaps other things we can do to reduce afterload pressure, like maybe reducing sodium content in the diet? A lot of foods have a high amount of sodium in them. I mean, are there other little things that you might encourage the pet owner to do in this situation other than just going straight to PIMO? Although I do tend to draw quickly on PIMO.
Yeah. No, those are absolutely fantastic points. I appreciate you saying that, Dr. Ward. Yeah, there's certainly other things we can do. I agree wholeheartedly about maintaining optimal body condition. Not too lean, because if they do get further down into the stages or stage C and develop congestive heart failure, we struggle with keeping lean body mass on, and then certainly not overweight. Because that presents or can make the heart work harder, if you want to think of it a very simplistic way. And it's going to put that dog at risk for metabolic diseases, diabetes, systemic hypertension, etc. So that's absolutely important. I think from a nutrition standpoint, although we don't have a lot of direct evidence to say dogs need to go on a cardiac diet or benefit from low sodium foods, I think it's going to do very little harm, particularly cutting back on the sodium. That's going to promote fluid retention, which is, again, a simplified way to think of it. It's going to make the heart work harder. So particularly avoiding high salt foods, snacks, treats, which are a lot of the jerky-based things. I think that's going to be another kind of best practice recommendation. The ACVM guidelines that are put out there aren't very specific, but I think, as you've kind of alluded to, staying away from the high sodium foods are going to be ideal. I don't think we know necessarily if cardiac diets specifically formulated for heart disease are a benefit in this subclinical stage, but once they reach the stage of heart failure or are very close to it, I think they're likely to do more good than harm.
Yeah, and one other final thing is just aerobic activity. I mean, so you've got that little 13-year-old. Maybe you do need to encourage them to take a few more extra walks or extra long walks because, again, remember the heart is a muscle and it can compensate tremendously if we just kind of work it hard enough. But let's get back to a slightly different variation. This 13-year-old now is having some occasional coughing and perhaps we even see evidence of pulmonary edema on the x-ray. How does that change your clinical guidelines?
Yeah, that's huge. I would say that's where we transition from so-called stage B, subclinical or preclinical, to now stage C, and that patient is in congestive heart failure. That's going to pretty dramatically change your prognosis once you've reached stage C. It is pretty likely that patient will die from cardiovascular disease or complications from it once they've reached congestive heart failure. Whereas in stage B, upwards of somewhere between 30 to 60% of dogs or more might not even die from their heart disease per se. So once you've documented pulmonary edema, that's going to prompt, if they're not already on vetmedin or pimobendan, it should be started in concert with a diuretic like furosemide. Not much has changed. I mean, Lasix is still our go-to diuretic. And particularly, I think most of us cardiologists will agree, once they've reached the stage of congestive heart failure, that's where drugs that antagonize the renin-angiotensin-aldosterone system are thought to be beneficial. The evidence isn't overwhelming in support of them, but at least in my view, they're likely to do more good than harm. And quickly, I just wanted to add that it is somewhat debated whether cough is a reliable sign of congestive heart failure, so pulmonary edema. I think what we can say is cough is commonly associated with more advanced or severe cardiovascular disease, but just because the dog is coughing and has a murmur, it doesn't necessarily mean that patient is in congestive heart failure. That's where we ideally would do thoracic radiographs to look for pulmonary edema. Old small breed dogs can cough for numerous reasons, one being severe heart disease, but they don't always necessarily have pulmonary edema. They could also have comorbid conditions like tracheobronchial malacia or tracheal collapse, chronic bronchitis, et cetera, et cetera.
Well, and even back in the day, we always were speculating that it was actually the enlargement of the left atrium that was causing tracheal, pressure on the trachea, eliciting a cough. So I mean, I 100% agree with you. But now we're getting back to that, and so obviously Pimobendan and Lasix, without a doubt, that's the foundation. But I think once again, I want to remind people, systemic hypertension is a real problem now that we get into stage C. So any little tricks there for managing hypertension? Because I personally have seen that a lot. I'm not sure if that's a common occurrence or if I'm just looking for it more frequently or.
Yeah, I mean, I think if you're looking for it, you're more likely to see it. So I would say kudos. Absolutely, you'd want, if you haven't on that patient gotten a baseline blood pressure, systemic hypertension isn't usually going to cause heart failure in and of itself, but it can certainly precipitate it or exacerbate it in a patient teetering on the edge. So checking that blood pressure and at least ruling that out is a great idea. And if you do have consistent readings of elevated blood pressure, I'm even more going to be supportive of starting a drug like an ACE inhibitor, enalapril, or benazepril. They've got relatively weak vasodilator properties. Their benefit is probably more in inhibiting neurohormones like angiotensin II and their effects on the heart. But if you've got a dog with what I might call moderate to severe hypertension, that's where absolutely we would consider more potent vasodilators, drugs like amlodipine, to add into that regimen, in addition to Lasix, Pimobendan, an ACE inhibitor, and even spironolactone as well.
Yeah. And one thing too, I think that sometimes we sort of have this misrepresentation. We all have an older relative with heart condition and they're on like 15 different drugs. And in my experience, Dr. Visser, most of the cardiac patients I've ever managed, it's like 3 drugs. It's rarely beyond that. So I don't want people to feel overwhelmed, because I think sometimes that client sitting across from us, as soon as they hear heart disease, they instantly go to their aunt or uncle who struggled with tons of different problems and complications and medications and constant rechecks. And for me, at least in my practices, I didn't overcomplicate it to that extent. Does that make any sense? Or hopefully I'm making sense.
I think that's a fantastic point. I mean, even just hearing heart failure, organ failure, has very negative connotations. So I think particularly from a general practice where a lot of you all are trusted by your clients, whereas they just come see a specialist, that might be their only visit. Some of these dogs we're managing chronically, but it's important to emphasize, what we mean by congestive heart failure. So now their heart disease has reached a point to where they've decompensated and their body is retaining too much fluid within the lungs, is probably a good way to put it. But despite it being called congestive heart failure, and it's likely that their pet will ultimately die from this disease, that doesn't mean that dog can't have an excellent quality of life for a significant period of time. Now, if you look at the literature in roughly average how long most dogs live with congestive heart failure, it's about a year, somewhere between 6 to 18 months. But and again, that's an average. Some dogs can do better. So we often yes, it depends on how you frame it. There's negative connotations with a dog being diagnosed with congestive heart failure, but that doesn't necessarily mean they're going to need humane euthanasia in the next weeks to months, and potentially they can go longer with years. We can manage this disease or congestive heart failure. And I like what you said. It doesn't have to be complicated with drugs, and we can certainly prioritize them. And the evidence is a strong support. If you're just going to pick 2 drugs, which I think would be best practice, it would be furosemide and vetmedin.
Yep.
There's more recent evidence to kind of question the efficacy of drugs that block RAS, like ACE inhibitors and spironolactone. So if you want to just simplify it, absolutely, you can boil it down to 2 medications. And certainly, if a dog becomes refractory to those 2 medications, even that's not endgame in and of itself. It might be, but I would say a more common scenario is, dogs are going to teeter in and out of what we call compensated versus decompensated states. They're going to retain fluid again. And technically, yes, we'll say they're back in congestive heart failure, but that doesn't mean a bump in at least the furosemide and sometimes even the vetmedin might get them another several months of excellent quality of life.
Yeah, I'm glad you mentioned that, because the therapeutic ceiling for these drugs, especially vetmedin, I mean, you've got a lot of headroom there, at least in my experience. And so I hate it sometimes when people they get up to that upper limit of what is published on the label and they're like, oh, that's it, I'm done. And I'm not sure, but I know that's off label. I don't want to get into that discussion, but guys, there's a lot of headroom with a lot of these drugs. And pimobendan, it's changed the game. I mean, if you go back when I was a young veterinarian, Dr. Visser, 30 years ago, we dreamed of interventions like this. I mean, we were really playing lots of games, and with enalapril in the early days and just trying our best. But once Pimo became available to us and then more affordable, wow, it was a game changer for sure. Well, I do, before you go today, I want to talk about a very, very common scenario. Let's get back to that 13-year-old. And it's, again, asymptomatic, but we're hearing a pronounced murmur. And wow, the teeth really need a cleaning because that's not helping at all. So what about some anesthetic considerations, both for that asymptomatic case where we've got a fulminant murmur, but also the one who's maybe in that early, C stage that we still need to do some kind of dental work or some anesthesia. We could even say it's a biopsy. It doesn't matter. But, anesthetic concerns, I think, keep a lot of vets away from doing more good. And, I don't know that always the risk is as great as they might fear.
Yeah, absolutely. It's probably the most common scenario. We kind of alluded to this earlier in that they're presenting for their dental or a biopsy, and they have now this incidental murmur, which is probably annoying because you have to go chase that, and that's not what they're here for. And the owner didn't expect to spend money working that up. But like we talked about, a thoracic radiograph is going to go a really long way. So in that asymptomatic patient that needs a dental, it's not too different from the general workup. We just need something to tell us about the hemodynamic significance of this presumed mitral valve regurgitation due to myxomatous mitral valve disease. And again, echo is going to be the best for that, but it's for many reasons not always possible. I wish there were more of us and we could get to your practices to help you out, but that's just the reality. So that's where thoracic radiographs, again, are incredibly useful. So staging that dog, again, using the cutoffs of vertebral heart score or vertebral left atrial size, either one, and determining whether or not that dog needs to go on or should go on vetmedin is going to be a huge advantage as far as anesthetic risk. So for example, let's say you do a vertebral heart score and it's less than 11.5. Well, I think you can be reasonably confident that that dog only has relatively mild or at most moderate myxomatous mitral valve disease. And most of those dogs tolerate general anesthesia quite well. We'll talk about kind of the cardiologist in me's approach to anesthetic recommendations in a minute. So just staging that dog, stage B1, determining if their vertebral heart score is less than 11.5 or their vertebral left atrial size is less than 3. They're unlikely to be in stage B2, and they're unlikely to need vetmedin at this stage of their disease. In a patient that has congestive heart failure or is symptomatic and is coughing, we certainly want to get them on their congestive heart failure medications. Again, at least furosemide and vetmedin, but at least in my opinion, probably also enalapril or benazepril, and potentially even spironolactone, is going to be a huge benefit as far as stabilizing them for anesthesia. But I think particularly at that stage, we have to evaluate risk versus reward. How bad are the teeth, and how bad do they need this biopsy or dental? Because once they've reached the stage of congestive heart failure, they can be quite tricky to manage under general anesthesia, and that risk is gonna go way up. So again, I alluded to this, but the bigger the heart, the higher the risk for anesthesia, the more severe their mitral valve regurgitation is.
Yeah.
Now, assuming that they need that general anesthesia, maybe it's a foreign body surgery or something like that, or they have just horrible dental disease, and that's affecting their quality of life more so than their heart disease is. I guess I look at it, again, I don't do general anesthesia, so I have the luxury of having board certified colleagues that do, but I think they would agree with me. I kind of look at it with three things, and it's more not what to do, it's what to avoid.
Right.
So avoiding the alpha-2 agonists, hopefully that goes without saying, dexmedetomidine, for example, is going to be less than ideal. The only good thing about those drugs is they're reversible in the setting of heart disease. And then keeping your anesthesia time as brief as possible. Sometimes it's easier said than done. You don't know what you're getting into until you're in there. But, it's not one where you want to train a newer colleague on the dental procedure. It's where you want to get in and get out. And then lastly, being relatively conservative with your IV fluid rates while they're under general anesthesia. So not necessarily using specific drugs that I would recommend. It's more avoiding certain things.
Yeah, and I appreciate you saying that, because I think the most important clinical decision that I make is what's the impact here on the quality of life. And so, there are a lot of times when you're dealing with that case who's already, into congestive heart failure, where it's just not worth the risk, in my opinion, right? I mean, unless it's causing undue pain or there's somehow I'm going to extend their life, but at the end of the day, we're now looking at months, instead of years, most likely in those cases. And so I'm going, how will this impact this patient 6 months from now? Is it worth the risk today? So I think those are great. You really, I appreciate you kind of being candid about some of those conversations that we have to have. Well, listen, finally, as we sort of wrap up today, any last bits of advice? Because I do feel, and it certainly has been my experience talking to veterinarians all over the country and the world, they fear the murmur. And any last bit of wisdom to help them say, look, maybe I don't need to be so fearful of every murmur, right? I mean, because again, murmur doesn't mean disease, and murmur doesn't mean imminent death, and murmur doesn't mean I have to change everything right now, right? So maybe give them that last bit of confidence from a cardiologist at Colorado State University.
Absolutely. I appreciate the opportunity. And I'll mention one other quick thing about VetMedin. So yes, I don't know, maybe a good fear of murmur is good, but not too much, because you're exactly right. A murmur doesn't necessarily mean the patient even has cardiovascular disease. I would say in the context we've been talking about old small breed dogs, it's a pretty safe bet that dog likely has myxomatous mitral valve disease. But for me, it's all about heart size. It's a relatively crude but a very robust, reliable way to tell if that patient has clinically significant heart disease. Because if you're scared of murmurs, no, we're not talking about cats, but you're going to hear a lot of murmurs out there, particularly in the older small breed dogs and tons of cats. So it really comes down to heart size. And fortunately, we can use tools like Vertebral heart score. We didn't have time to get into it, but also NT-proBNP. These are things that can help us or guide you from a general practice standpoint or non-specialty practices. Okay, do I need to care about this murmur at this time? And again, to go back to the radiographic measurements, if they're closer to the normal values or less than 11.5 using Vertebral heart score, I would consider normal roughly around 10.7 or so. If they're less than those cutoffs, I think you can be really confident that this dog's murmur doesn't have clinical significance at this time. Or if you're less than 2.5 vertebral bodies on the vertebral left atrial size, it's very unlikely that that patient is going to go into congestive heart failure or be at significant risk for anesthesia or to develop clinical signs from the heart disease. So if you hear a murmur, that should prompt a knee-jerk reaction to try to get an assessment of heart size, whether that's by echo, x-rays, or even using a biomarker like NT-proBNP. And last but not least, I think there is also some confusion out there about pimobendan, and I don't know if some of you have heard about this new Vetmedin CA1 versus Vetmedin. I mean, to cut to the chase there, it's the same drug, except Vetmedin is labeled for dogs in congestive heart failure. That's what the clinical trial was based on. And Vetmedin CA1 is labeled for stage B, or the asymptomatic patients. It has to do with conditional approval by the FDA. So I just kind of wanted to quickly address that confusion out there. And then if I can, one other quick one related to is we get a lot of questions about using compounded pimobendan or Vetmedin. It might be cheaper to the client. I would say we just don't know, right? These clinical trials that evaluated used Vetmedin for congestive heart failure, and then also using the EPIC study in the subclinical stage. Those were based on the specifically formulated drug made by Boehringer Ingelheim. So it's not that I'm opposed to compounding of the drug. We just don't have the science based on the compounded formulation. So it is somewhat of a risk to use the compounded form of the drug. I couldn't resist, Dr. Ward, adding those last two things there, just because we get asked that quite a bit.
Yeah, and me too. I actually had a vet not too long ago refer to CA1 as Vetmedin Light, and I was like, no, I'm sorry, that's not what it is at all. It's actually a label issue. Talk to the FDA if you want to get more details. And I really appreciate that comment about the compounding, because obviously I believe in compounding drugs whenever possible.
Yes.
But these are those areas. There's certain drugs that I just check off my list unless I absolutely have an imminent need for it. The dog will not take it any other way, because I think that Vetmedin is pretty easy to do. But again, you guys can hopefully see my enthusiasm for cardiology. I hope that you've gained a little bit of confidence and insight from Dr. Visser today. And again, I can't thank you enough for sharing your expertise, Dr. Visser, because it's a real joy to talk to somebody who is as experienced, knowledgeable, and passionate about this disease state. So thank you so much.
Absolutely. I'm more than happy to help. You guys are pretty savvy. You can look up my email, but it's just my name at colostate.edu. If I can help clarify any questions based on this, I don't mind whatsoever. Like Dr. Ward, it's a passion of mine, and I'm just happy to help. We're here to help the pets.
It shows, yeah. And we'll have all that information in the show notes. Well, listen, guys, I want to thank you so much for spending time with me and Dr. Lance Visser from Colorado State University. Again, it was brought to you by Boehringer Ingelheim, one of our preferred partners. And again, if you're more interested in learning about, Vetmedin and how you can apply it in your clinic, or you just have technical questions, don't hesitate. We can hook you up with those folks to give you the information that you need, because at VerticalVet, we're here for a simple reason, and that is to help you do better in your world. And so I hope that this helped you do a little bit better when it comes to managing your mitral valve disease patient. So on behalf of the entire amazing team at VerticalVet, I am Chief Veterinary Officer Dr. Ernie Ward. It's been my pleasure. We'll talk to you soon. Bye.